Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspective and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Jason, thank you for being here. This is fantastic. Why don't you go ahead and introduce yourself? I love the tenor you're bringing here. Go ahead and introduce yourself.
So Jason Acevedo, I'm a private practice otolaryngologist in Abilene, Texas.
Military medicine.
Military medicine, I did my training at Walter Reed Army Medical Center, 4 years at Fort Sill Army Medical Center in Lawton, Oklahoma.
Great. And then you transitioned to your current practice setting. When was that?
That was so I've been through a few iterations. So I exited the Army in 2014, then went into a hospital-based practice for about 2.5 years, and then a single specialty ENT group for about 5 years. But for the last 2.5 years, I've been in a multispecialty group as a private practice otolaryngologist.
And where is that now?
That's in Abilene.
Abilene, Texas.
Been in the same town since 2014, just in several different practice models.
Okay. We're going to be all over with this vodcast. I think it's called a vodcast because we're on video now. It's a new word.
Not a misspelling.
It's not a misspelling on podcast. 2014, so 10 years, 3 practice settings?
3 different practice settings. So that's one thing I've really, it's kind of influenced me a lot, is I got to see military medicine, through residency, academia.
Yeah.
Got to see hospital-based employment, single specialty practice, and now multi-specialty. Because there's been so much evolution over time, and you don't pick up on this, but as a resident, there's all these different paths you can go down, and I don't think we always do a great job on educating residents about that. And ear, nose, and throat is kind of a unique animal that I see so many specialties where they just assume we're going to go into employment, and that doesn't have to be the way.
You used a word here, evolve, and I'm looking at our listeners or our viewers. Mark Dubin helped me learn that word evolve, right? And he's with the Caden Group up in Baltimore, Maryland. I just want to mention, is that interesting? We're 2 minutes into this and you're using the word evolve as well.
I mean, it's our clinical practice. It's our practice models. I mean, when I left residency, there was no Inspires, and the way we practice medicine has changed.
Acevedo, you just plugged a company.
Oh,
it's like, no, it's okay. Product placement. No, it's okay. No, that's okay. That's okay. Sorry. It's product placement. No.
There were techniques not available at that time.
Understood, sir.
And there's practice models that were not
absolutely
available at that time.
But to me, it's stunning over a 10-year period you've evolved.
Oh, 100%.
Because that's how fast, right? I don't want to put those words in your mouth.
No, I completely agree. I think you always have to have a 1 year, a 5 year, and a 10-year plan, and be looking where, the Wayne Gretzky thing, they asked him how he scored all his goals. He goes, well, I always tried to skate where the puck was going to be and not where the puck was. And I feel like you kind of have to do that with your career.
We know each other for a long time, and I have a feeling I might have taught you that 1 year, 5 year, 10-year plan, which makes me beaming of pride. Can you tell our audience why we know each other so well? Because one of us is a little bit older than the other.
So I was a PGY2 resident at Walter Reed, doing a rotation at DC Children's, and there was a new junior attending that had just finished fellowship at Boston Children's, and very energetic doctor named Rahul Shah, who kind of took me under his wing, and
we had a lot of fun there.
A lot of fun, yeah. And clinically learned a lot, but also we worked a lot on some research papers and have stayed friends, and just was a great mentor. And it's so funny. I see now on LinkedIn, the other resident from Georgetown that was with us is Neil Tanner.
Yes.
And Neil is now a plastic surgeon in Beverly Hills.
Yeah.
I'm a private practice ENT in Abilene, Texas. It's like I don't know if you could bifurcate. But Neil, I think he said it. I ran into him a few years ago. He said he learned so much from him.
Oh, well, that's so kind. He's up in Northwell in New York. But
is he?
Yeah. He trained. Yeah. Neil's absolutely amazing. But really, it's really great. Our specialty has people from all over. I saw, speaking of LinkedIn, I saw you posted, and you're very humble, but I think it's really cool. And it might be the way this podcast is going to go. You received a Distinguished Service Award or recognition from your medical school.
I did.
That doesn't happen to people as young as you. And congratulations.
Thank you. I still don't know how it happened.
I don't either.
It was alphabetical.
It might have been alphabetical.
There was an error, but
really, you've given back to the community. What did they recognize you with?
I think the gist of it was physician leadership, and partly I think that was kind of imbued in the Army time, but also I just saw there's a lot of times there's a leadership vacuum, especially in the physician community. And I think a lot of the struggles we face now are because we've abdicated the leadership role because we're so busy grinding, trying to take care of our patients and still carve out a little time for our families and our hobbies. So other entities have stepped into that space and now are dictating the terms to it.
Mm-hmm.
So that was kind of that, between the military medicine time and, some leadership stuff through the AMA, the Texas Medical Association, things like that, even internally with Texas Tech. So,
yeah, you're being a little bit too humble there. I would ask you, for our viewers, advocacy. How do you fit it into your day to day? How do you make time for advocacy? Is it your core work? Is it value add? Is it additional? Do you consider it an additional burden? You do a lot of advocacy.
I mean, I don't think of it as an additional burden. I mean, I think, speaking of evolution, as we evolve in our careers, we're that generation where work-life balance is probably a bad word. It's like a pseudonym for lazy. Now I see it now. You have to be deliberate about your bandwidth and you have to be smart about it. And everybody's different. I mean, when I was a resident, I wanted to be on every committee and council. I had to burnish my CV as much as possible. But that's not for everybody. And I think it's being intentional and being about what, look at it as what's your return on investment. I mean, the time or the money you put into advocacy, what are you going to get out of that? And I think there's some high yield opportunities. There's some probably not as much, but I think it's important to at least be on the team. We're all on the boat, but only certain people really. Do you know what I mean?
All right, let me try to. I love analogies and mixed metaphors.
Thank you.
All right,
I'm a master.
Okay, great. I'm a big Commanders fan, which we know about on this podcast. I forget.
I'm a Texas guy.
I don't mind. It's just like a good game.
Yeah. Well, you're not going to get one from the Cowboys.
Well, we used to, right? Let me take your analogy. So you were talking about a boat and a river.
Yeah.
What we're going through rapids right now. Let's take that analogy in healthcare. What big rocks do you see out there for private practitioners? And you can focus on Texas, you can focus on West Texas, but what are the big advocacy things that keep you up at night?
I mean
obviously it's payment reform, obviously it's pre-auths, but
right. So, I mean, the big buckets, I think, regulation / compliance, that the regulatory buckets, the compliance bucket, I think we, as ENTs, we all think of ourselves as these little islands, but if our islands don't form an archipelago, there's nothing better. But if we don't work together, we just can't keep it. We can't scale, and that's why there's so much consolidation in healthcare, in hospitals and insurance companies, even in other industries, banking. It's because when you face this huge regulatory burden, you can't do it by yourself. MIPS, MACRA, value-based. I mean, even large organizations are struggling to keep up to transition toward value-based care because it's very complex. So that, and then payment reform, we're seeing decreasing reimbursements, increasing inflationary pressure. So it's really couldn't squeeze on us. And then scope of practice, I think, is going to be a big one that we need to define that. I mean, I'm a believer personally in team-based healthcare, and I think advanced practice practitioners have a big role to play. But I don't think that needs to be defined for us. We need to define that. What that looks like. What is the boundary for a PA or English practitioner, or somebody else will do it for us?
I always like on these podcasts for people to get to know you. Your kiddos are 17,
15, and 7.
17, 15. Yeah. Do you ever get surprised sometimes when they make these statements and you're like, wow, that kid's smart?
Oh, all the time.
Yeah. That's how I feel right now looking at you. I'm like, man, this guy's smart. I forgot you were PGY too, but just what's coming out of your mouth, I'm like, did I just say this? I mean, you're so articulate, and I understand now why you emerged as a leader. I want to go back to what you said, but I also made a note here about winds, because you mentioned archipelagos, which started me thinking about the oceans, which started me thinking about the way the wind's blowing. Are you optimistic? Is the wind blowing against us, behind our back, for private practice, for otolaryngology, for advocacy?
I am an optimist. I think the glass is half full. I think we have to be forward-looking and not backward-looking. And, everybody's in a different place. And I have I have friends in every different practice model, and not just in ENT, in every domain.
Because you're a multi-specialty group now, right?
Exactly.
Do you want to let them know you're actually going to be leading your group? Congratulations on that.
Thank you. So,
was it an election or did you take it over?
It was not a hostile takeover.
It wasn't.
It was an election.
You were the last man standing. They said, "Who wants to lead it?" Acevedo.
It was.
Congratulations.
It was a cage match.
Congratulations.
Thank you.
So 16 physician multi-specialty group.
Correct. And then we have an additional, probably another 16 to 20 mid-level providers.
Wow.
We're in a growth phase. And our group, it's kind of been, speaking of evolution, been through evolution. I think it's been as big as 100 physicians, but
wow.
We were kind of in a nadir. But after COVID, we took on a corporate partner, a physician enablement company, which, can I say their name?
Of course you can say. I mean, you've already said Inspire.
That's true. I've already.
You say what you want, sir.
I'm not.
No, it's for real.
I have no disclosures.
Wait, what is the name of that?
So it's Privia.
Okay.
Which what they do is.
And what word did you use? Corporate.
They a corporate partner, and they. It's a very hard model to describe, but basically physician enablement is what they call themselves.
Okay, sounds like a.
They do our contracts and EHRs.
Okay, fine.
So we
contract in the EHR.
We get the EHR, and we get to hop on their contracts through an MSO.
Okay, great.
But it allows our group, our medical group, we have our own legacy tax ID under which we practice. So I tell folks probably the simplest way to explain it is the patients get a bill from Privia.
Okay.
The employees get a check from West Texas Health.
That is so articulate. We have Christopher Harris from our academy team, and he's smiling, understanding this. If Chris and I understand this, then I think the otolaryngologist will. That was super well said. I like the way you described that. Yeah. When did you, and they're called a corporate enablement partner?
They are.
That's like a really loaded term.
It is, but their model is they don't own the group practices. They don't want to own doctors. They want to
enable their success.
And
they do that through AHR and
through the contract. So they can aggregate these big contracts.
Absolutely.
In a way that we can never, I've got, 40 providers in my group. I can't go to here and say, give me more money.
And I know we're all over the place, but this is what makes it fun for our viewers. What specialties are in your group?
So right now, myself, ENT, plastic surgery, primary care through family practice and internal medicine, cardiology, podiatry, and OBGYN.
Wow, you really
pediatrics.
But you have the whole gamut. I mean, you've got medicine there.
And we're looking to grow because we are. I mean, the nice thing is being on in this enablement pathway is we can aggressively grow, and it's very easy to plug and play a physician because the problem, 25 years ago, I could have left residency, set up my own little practice, got some contracts, hired staff, and just gone on my merry way. But now, I mean, if I was a resident graduating today, I'd be scared to death to come out and do anything other than employment. So I love this model, and that we can kind of give them that warm hug to say, we will help you do everything you need to practice medicine, and you can be as active as you want in that process or as passive. If you just want to show up and see patients, great. If you want to dictate how much your secretaries get paid, that's fine too.
Yeah, I like it. I'm going to try to say this back to you. No, I can't say about because you said it nicely. Privia gives you something, but the check comes from West Texas.
Exactly. So
what did you say? That was really good.
So we, through this partnership with Privia, we're on their contract.
Right, their contract.
HR.
That's right.
So the patient, when they come to see me, they would
get a
bill through our MSO with Privia.
Yeah.
But my staff get paid through West Texas Health. So they're the billing, contracting, EHR.
But the autonomy is there, which I love.
The autonomy is there. I mean, nobody dictates how we practice. I mean, and when we take on new partners, we tell them, you practice the way you want. You're just financially accountable.
And we have our viewers out there just for full transparency. So you came up to DC here to freshen up on your tonsillectomy skills with me. What brings you here to Alexandria?
So I'm actually here for a national Privia conference.
Yeah. Could you mind telling the group why you're here and what that's about?
So mainly just to see Dr. Shah. Also, so Privia is having a conference. They bring in, and this is one thing I do love about them is that they actually put me through this physician leadership course last year. But I got to meet other practicing docs in different specialties. Georgia, Virginia, Maryland, Tennessee, California, Montana, all these different markets, and to hear what's happening because, medicine is like politics. It is hyper-local in some ways. And I was shocked to hear the way Medicaid works in California versus Texas. I mean,
yeah.
But it also helps, get out. you don't know what you don't know. And it's great to get around other smart people and be infused with the ideas and the things they're doing in these different regions. So I loved it.
This should be the Academy commercial. There's no sponsors for these vodcasts right now. We hope to get them. And Privia is not part of this. Inspire isn't, but I just think, no, yeah. I have disclosures, but not pertinent to Privia or Inspire, but think it's important for our members. I'm learning about your corporate enablement partner now. So that's why I think it's important. So that's why I was here. No, and today's a Friday. Yeah, you're here. So Friday and Saturday, spending your time learning about how to make your practice more efficient.
Right. And if anything, it'd be great just if a few residents hear this and just know that they have options. Me and another family practice doc in my group, we've gone to back to Texas Tech, mainly just to talk to family practice residents to say, hey, this paradigm of thinking you just have to go work for the hospital, that's not necessarily true. That through the evolution of medicine, there's other options. And that might be private equity. It might be a physician enabling group like ours, a multi-specialty. I mean, it is exceedingly difficult to just be a solo practitioner these days, but I think there are changes coming there to make that.
Yes. Yeah. I've invited myself to West Texas because all I know about West Texas is the show Landman and Yellowstone.
Which it's pretty much an accurate.
But Yellowstone's not. They go down there. Okay.
Right. They go down.
All right. So I don't want to. I know my TV shows.
Yeah. So you'll be well prepared.
But I didn't know. And could you tell me, what does a practice setting look like in West Texas? Are there smaller private practices? Or you mentioned that it's either employment or some of these corporate enablement partners. Do you have that?
So
and I know it's a broad generalization, but.
And I mean, in West Texas, I mean, in my region.
Yes. In your hyperlocal
region, there's another group that is hospital employed.
Okay.
There, Abilene is about 120,000 people with a service area of probably about 200 to 250,000. So we serve a big geographic region because West Texas is very big geographically. But and in the other surrounding areas, there's some private practice docs. There's a lot of hospital employment. Mm-hmm. There's kind of a broad spattering. Mm-hmm. There's some docs that are private practice coming in the tail end of their career.
Okay. So you still have the spectrum of providers.
There's still a spectrum. I mean, we're the only physician enablement type group. Mm-hmm. And I mean, we get teased kind of sometimes that, multi-specialty is kind of the dinosaur. Mm-hmm. I like to say it's like the megalodon that was always living in the bottom of the ocean. Now there's a come up and start feeding. But I think
Go back to that. Because I don't want you to be bullied. I've always had your back, especially when you were a PGY2 and services were yelling at you. Why would people tease end quotes you about a multi-specialty group? They think it's there to be pure.
I think it's hard in some way. I mean, number one, I think they lump multi-specialty in private practice. Like you can't compete with bigger entities like big hospitals or health systems.
Because you're heterogeneous.
Because we're physician owned, we're completely physician run, like we are autonomous, and we're responsible for every dollar that comes in and goes out. So that's a unique challenge.
Yeah.
And also there's some dynamics within multi-specialty groups.
Understood. We don't need to talk about that. I know I'm recording, but I understand, right? So can you tell me, and this is completely off script. I have a script here. If it's not obvious, folks, I'm not following you. How do ancillaries work in multi-specialty groups? And if you don't feel comfortable with any of those questions, you can just...
I mean, I feel 100%. I mean, because that's part of our strategic vision. Me, our CEO, our prior president, we talked about it. The way we stay viable for the next 10, 15, 20 years, hopefully, is we do have to do ancillaries because we can't scale in the same way that, for instance, say a hospital could. We can't offset physician salaries with MRIs and CAT scans, admissions and surgeries. So we intentionally have had to look, what are other ways we can augment physician compensation to get to parity? So we looked at things.
With decreasing reimbursement, that's what you mean by parity. How do we stay whole?
Exactly, because,
and inflation.
Reimbursements are going down, inflation's coming up, and I could understand if I was a graduating resident and I get an offer from this multi-specialty group that's M.
Absolutely.
And the hospital's X plus 30%. I mean, it's just...
Yeah.
So we're trying to close that delta with things. So as surgeons, we can invest in ASC, which we're doing with our group. Outside opportunities, I mean, things you can invest in, imaging centers, lab,
So you still do that as an MSG, multi-specialty group.
We have kind of done it as a separate group because we didn't want the entire group to
Sure.
have to invest.
Sure.
But you can incorporate things like in bylaws of your LLC to say you have to be a member to have access.
Absolutely. So you offer that to the providers.
We do to say, hey, this is an investment for our group, but you don't have to participate. And even other things. So the other big driver, we've got a research partnership company that's I don't want you to mention that, but you have a research partnership. We have a research partnership. So
the multi-specialty group.
The group does. So what they do, they're kind of an aggregator as well, that they can go to all these big pharmaceuticals and they need to enroll patients. So we're an enrolling site. So
understood.
The patients get free access to the trial and sometimes get paid. And then that brings in some revenue for us.
So Dr. Acevedo, that's fascinating. So those people that are teasing you, now you can flex because as a multi-specialty group, you have the diversity of patients.
I mean,
right? You're not just otolaryngology, you have OBGYN, PEDS, IM.
And I think, and that's the thing, we want to have this ecosystem of where whatever the patients need, we have it.
Yeah.
And then the other thing, what we're headed to, by 2030, CMS is going to be 100% value-based. So we're 2 years into that and we're still learning, but we have some great primary care docs that are driving that change and we're starting to see the financial benefits.
Yeah. Can you expound upon that? Maybe you said something earlier this morning when we were having coffee. I won't remember your quote, but you actually see the potential for value-based care to be profitable.
Oh, it already is.
I whispered that word, by the way.
No, I mean, profitability, it's not a bad word.
I'm proud about putting it together.
Right.
Value-based,
And I would say, we are relatively new into this value-based model. There are other groups within Privy that are doing very well with it because it is a evolution, to come back to that, to go from upside risk only to downside risk. So there's a process you go through, but the more risk you take, the more reward you get. But we're already seeing the financial benefits of that partnership. And the further you go, the better it gets. Because I honestly feel like you're practicing better medicine. You're trying to keep your patients out of the hospital. You're trying to do surgeries as cost effective as possible and provide the best quality care at the best cost. And then you actually get rewarded on the backside.
Love that. We were talking a little bit earlier, and I'm trying to wrap this up because I'm having a great time, and you are too, but I have a feeling our listeners might have to see patients or get to clinic, so I want to be careful. You said this morning during our coffee about investing in ourselves, or you're talking something about that. Can you remind me what you were saying?
I mean, I think especially in the
believe in ourselves, something like
that. And bet on yourself.
Bet on yourself. That's the word.
I can't remember where I read it, but it was an athlete saying, sports betting, it's illegal for athletes to bet on sports. They said, but I feel like we should be able to bet on ourselves, right? Like, I think I'm going to win this game. Anyway, what I mean by that in our sense is that when we invest in physician-based things, we are betting on ourselves. If you're a surgeon investing in an ASC or a sidecar investment with, who knows, a sleep lab, whatever the case may be, I think that's how we can stay independent. And if you want to be independent, great. If you don't, because some people are W-2 type folks, some people are K-1 type people. I think if you have that entrepreneurial mindset and you want to be independent and be autonomous, you can do that. You have to take a little financial risk, but I feel like, why not bet on yourself? I mean, through any opportunity within the medical domain. And I mean, I think the way the system is set, I would definitely want to bet on ASCs because we got to make healthcare cheaper. We have to maintain quality and decrease cost. And the way you do that is doing surgeries at the cheapest. I mean, obviously you have to get the same outcome, but when you look at it, I even parse it down. I can do this in the office, the ASC, or the hospital. And if I do it in the office, it's X. If I do it in the ASC, it's 2X. If I do it in the hospital, it's 4X.
And what's best for the patient?
And what's best for the patient?
Some of them in the center of it, we know.
Now, you can't do a laryngectomy in the ASC,
right?
Obviously, but if you look at the procedure and
absolutely
the patient safety and acuity, and
absolutely
give them the best care and the best service.
Of course. I'm looking at Chris here. Chris is on our team here at the Academy, Christopher Harris. And Chris, maybe we call this podcast Bet on Ourselves, right? Maybe bet on ourselves to make us whole. I mean, you've given us a lot to think about when we think about it.
I mean, I think it's an exciting time. I think we are kind of in a paradigm shift in medicine as a whole, especially in our specialty. And, value-based, right now it's really focused on primary care, and that's where it has to start. But specialists are 60% of the downstream.
And are you seeing that? I don't want you to quote trivia, but on your national tours and learnings, are you seeing that value-based care works in surgical specialties?
I mean, I think we are just barely dipping the toes in.
Okay.
But I think it does. And I think right now, I think that the bigger entities that are doing it are laying the groundwork with primary care because you have to.
Yes.
But eventually,
And they're seeing successes.
they're going to see success. But I will bet you within 5 years, when a primary care doctor clicks refer for tonsillectomy, it'll get a list of EMTs and it has a list of costs, and they'll be able to see this guy does all his tonsils in the hospital, this man or woman.
And if they're in a VBC kind of contracting, they're going to have to think about that.
And you could almost be like a Google star. You have quality and cost. I mean, you could see, and we know our physician partners, this person has great outcomes and they cost half as much. And that cost falls back on me. Yeah. So I think we're going to have to become more financially accountable for what our patient care looks like.
Yeah. I'm going to go off script. And Chris, if we don't like this answer, we'll splice it, okay? Because that's the beauty of a podcast. And you can keep this comment about splicing in there because they won't know. What can I do for you? Today is day 5 for me. I am proud to be here. You pay for the rent of this place. You pay Chris and my salary. Thank you for giving me the opportunity of a lifetime to serve you all. What can I do? What can the Academy do?
I mean, I think that's a great question.
Good. Let's stop right there.
Let's stop right there.
No, but I'm serious. How do we help you be successful, whether you are employed, whether you're solo, whether you're part of a multi-specialty group?
Well, I mean, I honestly think the Academy, to use the boat analogy, the Academy is the boat because we're in different states, different practice models, different subspecialties. Like, ear, nose, and throat is such a diverse specialty in some ways. And so the only thing that really ties us together nationally is the Academy.
Well, I appreciate that. And I didn't plug you on that. Keep going on that analogy because, I might put this is my office for all of you. We're going to put aside, I am the boat. Or we are the boat, I'm the captain. But go with that because one thing is we're a small specialty. We are very powerful. It's absolutely stunning. And you know this or might not know this. Dr. Bruce Scott is the current president of the AMA and Dr. Bobby Mukamal is the president-elect. Yeah. So 2 years in a row, we have otolaryngologists. You look at health systems, you look at leaders across the country, otolaryngologists, right? Absolutely. So we are punching way above our weight. Go with that boat analogy because I struggle with sister societies and other organizations. We don't want to be fracturing ourselves.
No. Well, and I do think, I say that I also I'm active with the Texas Medical.
Absolutely.
It doesn't have to be a zero-sum game.
Yeah.
But I think the Academy needs to be part of your portfolio.
Yeah.
And I'm a big believer in ENT PAC too.
Yeah.
I think that's, I'll endorse it. I guess I can, but
yeah, of course you can endorse it. Let's solicit some donation.
Exactly. Give now.
Yeah. But
Dr. Shah will match.
I can't legally match. That's why I got to scare. But let me give you a stat. And we'll end with the ENT. Well, you finish your statement. I'll give you a stat.
No, I was just going to say, I think the Academy needs to be part of your portfolio because, and not just even the advocacy part, but where else to meet a group of people like you meet at the Academy meetings, at every practice, a guy practicing in rural West Texas or somebody that's in Manhattan.
Yeah, pretty cool, isn't it?
Facial transplants.
Or a colleague from Nigeria who leads the International Advisory Board or Europe.
Yeah, exactly.
Yeah.
So what better place to meet other people that are in the same phase of life and do it?
I'm stunned by the global reach. When I took this job, I understood it, but wow.
Oh, and
we can help patients all over the world.
When I was checking in Miami, the international check-in line was longer than domestic. I was blown away.
Is that cool? Because we're learning from each other. I was giving a Academy update at the Society of Otolaryngologists AAO-OBDO meeting in Phoenix, November 24th. And I stood up there. I had 15 minutes, and I spent 3 minutes talking about the ENT PAC. And I mentioned that our investors, we call them investors, we had 1.7% of our members investors. That's embarrassing. So on Wednesday, I'll be going to Capitol Hill with Mark Dubin, Lance Manning, Mara Farrell from our Academy team, Harry DeCabo, and we have terrific meetings set up. Terrific, because we're going to advocate. You know what they asked me, Jason?
What's that?
How many members do you have? 15,000. Then you know what they asked me? By the way, how many investors do you have in your pack? And when I say 1.7%, that's how does it make it?
Kind of takes the air out of your.
Yeah, so I appreciate you. So I made a call at that SEWO meeting and I asked the group to join us as investors. And the cool thing is, yeah, dollars help, but it's actually numbers.
Yep.
And in 15 minutes, we added 40 new investors. Is that amazing? And what made me more excited, it was our academicians, because we are one.
Yeah.
Right? Prior aughts, heard all of us. Right. No Surprises Act, the other advocacy efforts, scope of practice.
Right. Well, and I was going to say, one of the questions that was on the script,
which we didn't follow. We had 17 questions here. We got through number one.
They were not good questions. But it's Texas local, but the Texas Medical Association is one of the stronger.
Yeah, very powerful
state lobbies.
Yes.
But they were able to get some legislation passed to do what's called a gold card.
Yes.
So we have gold card legislation.
Can you explain that to our members? It's pretty cool.
It's pretty cool. So basically what it does is if you meet certain criteria, you are exempted from the prior authorization process for commercial payers.
Yeah.
So for an entire calendar year, you don't have to do any PAs.
Meaning like your PAs, your prior auths have gotten approved over and over and over, and they know that you're
high quality. You're not submitting a bunch of junk.
Yeah.
So I think that's exactly. And it was a lot of work, and through my work with the team, I see how much it is. I mean, they have an entire lobbying team that is down in Austin working their tails off to make this stuff happen, and we have to do the same because if we don't have that seat at the table, when they have these votes for, okay, we're going to cut physician Medicare reimbursements 2.8%.
Not pertinent to us, but did you see yesterday and they pulled back? Did you hear that they wanted to cap the anesthesia times? Or you might have been on the plane when that hit the wall.
No, I did.
Is that insane? So they would say let's take tonsillectomy, they would pay for 15 minutes. What if that kid goes into post-obstructive pulmonary edema? What if there's a bleed? What if it takes an hour and a half? They wouldn't. Where does that make sense?
Well,
and thank God what insurer was putting that through was like, oh, I made a mistake.
Well, and I think
that was advocacy.
They have weaponized our compassion to where they know we always do what's right for the patient.
Chris, this guy's a mic drop all over. Weaponize their compassion.
I mean, it's true.
It is true.
It is true because we will always do we're not going to let a kid bleed to death.
Right.
No, I'm not going to get paid to fix that.
And you are going to do that surgery for that 81-year-old mother that has a cancer.
Yeah, or the uninsured patient that walks in.
You will always take care of it.
You're going to do it. But that's become a weapon against us because they know, well, we can pay them whatever because they'll just take it.
Yeah. And things like the EMT pack and other ways contribute. I couldn't be more proud of you, and it gives me chills. I'm thinking of times we were in the OR, and I'm sorry if I yelled at you, but I mean, listen, man, you got to take out the tonsil the right way.
Put some bark on the tree. I'm tough now. I can handle it.
Very impressed with your career, and it actually gives me much gratitude to know you're out there fighting for us, and you're here in DC. So usually we give a shake, we give a bump. Any Texas way you want to send everybody? How do you send them out? Well, this is hook 'em, but that.
Oh, we don't do that.
So
actually, I'm an Aggie, so
we do this. All right, so this is how we do it.
Yeah, even after that last game.
All right, so you'll get me ready to come to West Texas.
You'll have a boot, boots, a hat.
Yeah, but I don't want to do this when I should be doing this.
Don't. Not in my, if you go closer to Austin.
All right, not in West Texas. Thank you very much for your advocacy.
Got to meet your
honor. Thank you.
Thank you very much.